Hello, ma'am. It is audible.
Yes.
Yes.
So, Dr. Meena, we are going to start a Pipac demonstration. Okay. So, I have prepared a few slides, which are very preliminary slides. And there is a caveat. I have just learned about this procedure in my stint at Singapore. So, I thought my residents should be aware of what Pipac really is. So, we are going to, in the next few slides, understand the basics of Pipac.
Okay, ma'am.
So, shall we start?
Yes, ma'am.
Okay. So essentially what Pipac means is pressurized intraperitoneal aerosol chemotherapy. As you can see in this diagrammatic representation, I can't see a cursor. Can we have a cursor here? No, the cursor won't show. But you can see that there is a pressure injector on the right side, okay, in blue, and through which the drug, which is chemotherapy, is injected into the peritoneal cavity after establishment of a normal this CO2 peritoneum, pneumoperitoneum. So the speciality here is that these trocars are not normal trocars; they are balloon trocars. As you can, I'll show you in a while also in the demo. These are small balloons. The function of these balloons is to hold this port tightly without any air leakage, which is of paramount importance in Pipac. Okay, so this is the inflow tract here, and then we have another 5 port where through which we put in a camera port. It's also a balloon trocars, and then there is a closed airway suction outlet which is connected to this trocar. So essentially we require only 2 trocars in this process. Sometimes we may require 3 in case we require to do some peritoneal biopsies. So why Pipac is necessary? It's quite a recent procedure. It was first introduced in 2011, and human efficacy was first shown by Solas et al. From Germany in 2014. As we all understand, there is some systemic chemotherapy has great limitations beyond a point, and in patients for largely palliative purposes, nothing much is left rather than best supportive care. And perhaps we have some role by using Pipac in these settings. So there are certain contraindications that we must know before we know about indications. If there is florid extra-abdominal metastasis, ECOG status is extremely poor, patient is in bowel obstruction, or there is significant intra-abdominal adhesions or disease so that effective pneumoperitoneum is not established, these patients are not candidates for Pipac. And again, it's the standard that if any patient has any allergy to any of the chemotherapeutic drugs, definitely you cannot go ahead with it. So what are the indications? Indications remain a refractory or recurrent peritoneal metastasis, inoperable disease in a way that PCI is too high for any standard CRS or Pipac. There is palliation for ascites management. Sometimes Pipac is being used as a bridge surgery. You do repeated Pipac and patient becomes a candidate for HIPEC in some time. And definitely when there is multiple chains of chemotherapy have resulted in failure. So what is basic principle governing this? There is a specialized pen. I will be showing you in some time, the Capno pen. This was a prototype. It's a type of nebulizer. There are other companies also manufacturing it. So it causes aerosolization that you can see. This is the pen, that how it looks like, and this is what nebulization actually means. This is how a shower, Swiss snowstorm appearance of the drug that comes out once it's in use. The nozzle tip is very fine. It's only 0.2 millimeters, and the spray cone angle is about 70 degree. The mean droplet size, as you can see, is approximately 25 micrometers. It's extremely small, beg your pardon. The flow rate can be 0.5 to 0.8 ml per second. That is corresponds to about 30 ml per minute. The injector pressure is very high. So it's the same injector that we use for CT scans, angio injector. And the pressure may rise from 15 to 20 bars as per the requirement and the size of the patient. However, the intra-abdominal capnoperitoneum is standard, that about 12 to 15, again depends upon the size of the patient. So the advantage here is that you are giving high local concentration with very low systemic toxicity. And the other part which is very good is that it can be repeated at least 3 times after 6-week interval. So how we do it, I will show you in the dry demo also, but just a brief. we need to stage the PCI assessment, preferably with an MRI, and do repeated MRIs to assess the disease progression or regression. And in the initial part, we do a diagnostic laparoscopy and find out the PCI surgically. However, the port placement should be minimal. We use generally two are advisable, 5 mm for camera and the closed outlet suction, and 12 mm for the capno pen. And it is advised that every time you go in, you should do at least a 3 or 4 quadrant peritoneal biopsies. These are very small 3 mm, 5 mm biopsies. No adenolysis is permitted because Pipac can cause if there is a serosal tear in the intestines while doing adenolysis, there might result in perforation. So all that need not be done. And then we put in this nebulizer or the capno pen, which should be free floating inside the abdominal cavity with absolutely no bowel contact. And once it is all set, all staff moves out of the OR and aerosol chemo delivery is done either with a remote control injector, or the wire should be such that it can come out of the theater. And as for anesthesia, as Dr. Ray was discussing during his surgery, and that sometimes or most of the times it is only not inhalation but IV anesthesia is used, so that everything can be controlled outside the OR. So essentially it's a closed exposure, and once the procedure is over, one person enters into the OT and stops the CO2 and opens the exhaust valve. So it's a closed suction drain. There is no contamination in the OT atmosphere. And once that is done, the rest of the team enters. Other important point is that all these are disposed of as a chemo disposal system, completely separate of all the things without contamination. The nebulizer generally takes 7 minutes to deliver the drug, depending upon what kind of drug we are using, right? So if there are 2 drugs, they are given one after the other, and thereafter a total time of about 30 minutes is left for the drugs to act in the abdomen. So it's quite a short procedure, so to say. So what are the drug protocols that we use in appendix and colorectal? It's mainly oxaliplatin and mitomycin. If the patient is allergic to oxaliplatin, I'm not sure if mitomycin is available in India. Dr. Neha will tell us. As far as ovarian, gastric, hepatobiliary and mesothelioma, it's a double drug, which is cisplatin and doxorubicin. A word of caution is that these are not yet FDA approved. There are off-label use that we are doing, because Pipac is still under phase 2 trials in most of the centers. And I think in UP we are the first center to demonstrate it. It hasn't been used anywhere in UP to the best of our knowledge. So what actually are the outcomes? We are hoping to achieve a peritoneal regression. There is a separate peritoneal regression grading that has been advised, and I'll just go through it in a while. There is good control of ascites. It has a downstaging potential. The best thing about it is it's a short procedure with minimal morbidity, right? And it can be sandwiched with systemic chemotherapy in the same sitting. So we don't have to wait for any week or 2 weeks or 3 weeks before we can start systemic chemotherapy immediately after Pipac. Similarly, bevacizumab is also not a contraindication. Unlike in Hypac, we have to wait for about 4 to 6 weeks before we start Hypac in a patient who has been treated with Bev. So as I was telling you, this is the peritoneal regression grading score, and it was again proposed by Solas et al. From Germany. And it scores from 1 to 4. As you can see, it's a pathological grading where 1 is complete response and then 4 is almost no response. And it depends how many tumor cells are left, what is the kind of fibrosis that remains, right? So this is how you, after every time you do a Pipac, then you see how much the tumor has responded. So safety remains paramount, although this procedure looks very safe overall, but you have to be very careful while using it. It's a closed system. There should not be any contamination of the OT. The OT should preferably have a laminar airflow, HEPA filtration, or a closed, if you don't have that, you have to have a smoke evacuator system so that the exposure to the staff is negligible. Although there have been many studies that even otherwise exposure into the OT atmosphere is minimal, negligible. But over a period of time, it can cause harm, which nobody knows as of now. So it's best not to have any exposure to the best of our ability. So with this, where Pipac fits in today is perhaps this. In resectable disease with low to moderate PCIs like CRS and HIPEC, we are doing as a curative procedure. For borderline cases which are potentially downstage, maybe there is a role of Pipac in the neoadjuvant setting along with systemic chemotherapy. That's a bi-therapy. And if the patient gets sufficiently downstage, they can proceed to CRS with HIPEC. Unresectable disease, of course, there is a definite role in palliative settings. So with this, in some time, I will show you from the theater how the capnopen actually works. Thank you so much for your kind attention.